Welcome to today's Echo, and I'll get started as folks trickle in. So today's event is identifying breakdowns in infection control and recognizing risks in healthcare. My name is Diane Apejuan. Today's facilitator is Kyle Mitchell. Our subject matter experts on board today are Karen Kwok and Marie Sefier. Welcome. Just a few housekeeping rules as we go through. Just a reminder to go ahead and turn on your videos, mute your microphones when you're not speaking, enter your name and organization into the chat. Please note that only introduction and lecture sessions of this presentation will be recorded for educational and quality improvement purposes. No protected health information is to be disclosed. So recording begins now. Just a reminder to mute your microphone so we don't hear the feedback in the background. We'll ask our IT to go ahead and mute wherever the sound is coming from. So today's agenda, we'll go through a brief welcome and introduction. We'll have an icebreaker session. We'll introduce Project Echo. We'll move into our lecture. We've included a quality improvement component. We'll review a case presentation. We'll open up for a discussion, and we'll transition into QI strategies, which is another component inserted into our Echo, and then we'll close. Next slide, please. So welcome to today's Project Echo. Continue. About NCUIH, we are a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians, Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V UIOs under the IHS in the IHCIA. NCUIH strives to improve the health of over 70% of the American Indian and Alaska Native population that lives in urban areas, supported by quality, accessible healthcare centers. NCUIH strives to create a broad awareness of Indian health issues while maintaining a visible presence in Washington, D.C. We track legislation and provide congressional testimony, as well as distribute news, resource updates, and legislative alerts. We hold conferences, webinars, and host an interactive website that helps to disseminate information and facilitates partnerships. Next slide, please. Project Firstline is a national collaborative led by the U.S. Centers for Disease Control and Prevention to provide infection control training and education to frontline healthcare workers and public health personnel. NCUIH is proud to partner with Project Firstline as supported through cooperative agreements. Both are named here. CDC is an agency within the Department of Health and Human Services. The contents of this program do not necessarily represent the policies of CDC or HHS and should not be considered an endorsement by the federal government. Next slide. Some of you might already be familiar with Project Firstline. Project Firstline is the CDC's national training and educational collaborative for healthcare, infection prevention, and control. Every frontline healthcare worker deserves to understand infection control principles and protocols, and the CDC's Infection Control Training Collaborative, Project Firstline, is committed to helping every frontline healthcare worker increase their knowledge and understanding of infection control. They aim to achieve this through providing clear and effective infection control resources.
You know where I was going, right? I was going to get these windshield wipers.
Yeah, so don't wait.
Hello, Mr. Ironmaker. Thanks for muting. I'll continue. They aim to achieve this through providing clear and effective infection control resources and CDC recommendations while also considering the needs and preferences of the healthcare workforce. Next slide, please. Most of you are familiar with our NCUIH's Project Firstline team. We've been providing educational webinars and echo sessions last year. We'll continue to do so next year. Next slide, please. We usually ask for survey responses at the end of our educational sessions. This helps us to build important information that you need for different types of training. It also lets us know how effective we are in communicating the information. Please take our survey at the end of this session. Let us know how we can serve you better. What we've done to facilitate ease of access is to provide a QR code that you can scan easily with your phone and complete the survey as we go along. It takes about 2 to 3 minutes. I'll also go ahead and ask them to drop the link into the chat for those who want to go ahead and complete this on the computer. Next slide, please. Our facilitator today is Mr. Kyle Mitchell. He's Dene Navajo and is a military veteran. After his discharge from the military, he attended South Mountain Community College and later Arizona State University. Kyle is currently a program manager from SMCC's Vice President of Academic Affairs and an adjunct faculty member of the SMCC Storytelling Institute. His work with urban natives led to the creation of Kiltso Bito, and he's corrected me on this, and I'll ask him to correct me again, whose company goal is to overcome stereotypes through contemporary and informative oral traditions. We move forward with 3 things: songs, prayers, and stories. So everything we do in our culture is related to those 3 things. And this is a quote from Kyle. And I hand over to Kyle. We're not hearing you. You're muted, Kyle. Do you want to go ahead and check your microphone?
Okay.
There we
Sorry
are.
about that, everybody. Good morning. Thank you, Diane, for that introduction. Hello, everybody. It is still morning here in Arizona. So I am Dene, so I'll do my intro. Yate, abene, she Kyle Mitchell, yenshe, twitchini, nishle, nakai basichin, ke ani desiche, nakai desinella. Kilsui bitwa, although chechna dozi danisha. So good morning. Thank you for having me today. Before we get started, I just want to ask, maybe if we just take a 5 seconds, a moment of silence in lieu of land acknowledgement. So that way we just pay reverence to the stewards of the land before we were there. So we'll commence that now. All right. Thank you. Next slide, please. We'll go ahead and jump in, both feet first. All right, so what is Project Echo? A telementoring program designed to create communities of learners by bringing together healthcare providers and experts in topical areas using didactic and case-based presentations, fostering an all learn, all teach approach. Some of the key takeaways: creates partnerships, encourages knowledge exchange, utilizes technology, and promotes case-based learning. All right, next slide, please. All right, so the anatomy of Echo, you can see here. The anatomy of Echo with the QI component for quality improvement. If you see this, hold on just 1 minute. Sorry about that. All right. Okay, so the traditional makeup of an Echo consists of the welcome and introduction section, followed by the lecture, in which Echo is sometimes referred to as a didactic, and is followed by an open question and answer component. The next section, which consists of majority of a time, is a case presentation and discussion. The case is based on the lecture and applies key information from the lecture. Then we close. This was the makeup of the closed Echo sessions last year when we worked with select UIOs as champions. This year, we will roll out year 2 of Project Firstline Education Collaborative. NCUIH is launching an open Echo, open to all urban Indian organizations, and we will introduce a quality improvement QI component for those UIOs who would like to implement QI into working cases that identify and share with us. Hence, this model, we will discuss a QI overview and follow our case presentation. We will look at QI strategies that can be used with the case presented. And so if you look at the diagram here, you'll see the table there of the pie kind of broken into the different areas we'll go into today. Next slide, please. All right, okay. NCUIH is now an Echo Hub as a result of the collaboration with the American Academy of Pediatrics, APP, who is a super hub and one of the partners in Project Firstline National Collaborative. NCUIH will use the CDC's develop training content, tools, and resources along with other approved resources to inform urban Indian organizations on the most up-to-date knowledge and strategies on infection control and mitigating infection risks as related to emerging and re-emerging disease threats along with COVID-19. All right, so NCUIH's Project Echo will allow a community of learners and the sharing of best practices amongst UIOs, case-based learning, mentorship, and support access to subject case experts. All right, next slide, please. All right. Okay, so some of the benefits from last year's closed Echo with UIOs, IPC system champions, assessment of infection control programs, development of policies and procedures around the infection control through collaborations, case review of on-site challenges and feedback from SMEs and peers, access to Project Firstline training content, contribution to the development of Project Firstline training content for healthcare workers on the front line. Next slide, please. All right, so I decided to switch this up just a, whoops, sorry about that. Sorry about that. All right, so I had an icebreaker planned for today, but in lieu of that, I would like to share a story. Just really quickly with everybody. So go ahead and sit back and relax for a little bit before we launch into this. In thinking about serving UIOs and the model for Echo and how that is sharing knowledge to the masses, right? Those individuals who don't have access to those subject experts. Within Diné culture, within Navajo culture, we have a story of how our medicine man started. And so I'm going to tell you just a little piece of that, and then we'll tie it into the overall presentation. So long ago, when the world was new, nothing like we see now, Navajos, we believe, emerged here. So in our creation story, we emerged here and there was nothing. But over time, there started to be monsters, right? All these different monsters that were tormenting people, taunting the people. And so what ended up happening was there was two demigods, you would say, and there are warrior twins within our culture and our legends. And so they went to go see their father. And when they went to see their father, the sun bearer, he told them what to do to rid the world of monsters. So the boys came back to Earth and they went through and they cleansed, pretty much the Earth of all the monsters that were plaguing the people. And during that time, there was a family of 6 boys, and they were up in, I guess, what we would know now as northern Arizona, northern New Mexico region. We call that Dinibica, the land of the Navajo. And so there was these brothers who were hunting one day, and they started looking around on what they could hunt. And they went up into these high mountains, and there they saw some mountain goats. And one brother took his bow and arrow, drew it back and let it go, and it bounced off of the mountain sheep. And so the other brothers tried to do the same thing, and then the ram, or the mountain goat, just took off further and further up the mountain. So soon all the brothers disappeared trying to find him. And there was one brother who was the youngest who was tasked with finding out what happened to them. And so that young brother, he went up to the top of the mountain, and then he saw the herd of mountain goats. And as he got closer to them, he started seeing them change shapes into an image much like him. much like us today with 5 fingers on each hand. And so he went up to them and he started talking with them. They told him that they were the holy beings, the entities there. And they were asking him what was going on, what he was doing. And so he told them that his family was hunting for food, that the monsters were all gone, but they didn't know what to do, that everybody still had a fear in them. They were scared to go out. They didn't know what to do. And so these holy people took the youngest brother and they started training him and teaching him all the teachings they have. And this took place, they say, for a long period of time. Nobody really knows. So we could kind of correlate that to going through medical training, right? Going to medical school, going to NA, an RN program, whatever those may be, taking time to learn a certain discipline. So finally, the younger brother was taken back home. And once he was back home, he started going out to the other Navajos in the area and the people. And he started using what he was taught to start healing the people, because the people were ravaged, much like we experienced as a nation and as a world 2 years ago, where everything was flipped upside down and we really didn't know how to get ahead of it. So this young brother was the first medicine man. And so what he started doing is he started healing people all over. And over time, he started identifying people and people who wanted to be healers themselves. And so he started teaching them, and that is how the whole structure started. And the reason why I bring that up is, again, using Echo right now, that young brother, once he started healing everybody, and once he started taking on pupils, he started teaching them. So much like we're learning today. And I think it's a great opportunity to think about that there has already been an indigenous framework for American Indians, for Alaska Natives there, right? But it's just having that convergence, right, of understanding where we go and how to disseminate the information to your organizations and then to the end user with your patients there. So today, as you're going through the presentations and as you're hearing from our amazing presenters, I would like you just to keep that in mind, that the ECHO model is an indigenous model, something that you can take, you can learn and apply back to your organizations. So thank you for that. Okay, so the main thing is it's an all teach and all learn, right? So hands-on learning, you're going to go through the case studies, you're going to listen to all of this. So it's learn, 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 and implement. So thank you for listening to me for a little bit. Now what I'm going to do is transition the slide, please. And I will introduce our first presenter. All right, so this is Karen. Karen holds a dual master's degrees in nursing and in public health and is nationally certified family nurse practitioner. She has over 20 years of experience working in health equity with resilient communities, including coordinating care for UIO patients, specifically San Francisco, California's Native American Health Center. She has provided direct patient care and service delivery operations workflow and infection prevention and control, and has prior consultancy experience in disaster relief with post-Hurricane Maria in Puerto Rico and CDC Biosecurity Project. Her public service is recognized with American Nurses Credentialing Center, Robert Wood Johnson, the Bill and Melinda Gates Institute, the California Governor Gray Davis, President Barack Obama, and Fulbright specialists. Participants, please join me in welcoming Karen.
Thank you, Kyle, for the kind introduction. Next slide, please. And next slide, please. I have no disclosures at all. Next slide, please. These are the learning objectives for our ECHO session today: to use risk recognition strategies to reinforce infection control training, apply risk recognition strategies to problem solve cases where breakdowns in infection control occur, and share resources to support infection risk recognition. Next slide, please. So what is risk recognition? It's understanding that risk recognition is important in infection control. Risk recognition is identifying the potential for a problem to happen. Once you recognize the risk, you can then take action to minimize it. Next slide, please. Let's briefly discuss infection control. The goal of everything we do in infection control for any disease is to keep people from getting sick. So, what does risk recognition have to do with infection control? Well, if you learn to spot the opportunities for germs to spread or recognize a risk, then you can step into stopping that infection and preventing that infection. Infection control is a critical part of safe healthcare delivery in all healthcare settings. Next slide, please. Healthcare is a unique setting, and we have to consider germs differently in healthcare than we do in other places like at home or in the community. Be alert for opportunities to spread when patients are more vulnerable to infection with germs. And because there are closer interactions between healthcare workers and patients, there's a higher chance for an infection to occur as patients seek care in healthcare settings. For example, consider droplets from coughing that can spread tuberculosis. A good question to ask yourself is it possible that a task that I'm about to do, could that cause germs to spread? Next slide, please. When reviewing workplace tasks that can spread germs in healthcare settings, let's take a step back and think about where germs live. How can they spread? And what UIO, Urban Indian Organization, infection control measures can prevent infection from occurring and spreading. Next slide, please. Germs are too small to see, but they're everywhere, including in and on our bodies and in the environment. A healthy immune system can protect us, but germs can be a problem if natural immune defenses are weak and someone is already ill. You can't always tell when someone is vulnerable to infection, so infection control actions in healthcare are important all the time. Next slide, please. So where do germs live? When you're thinking about the risk for germs to spread in healthcare, the first step is to think through where are you going to find the germs or where the germs live. Germs live in the body and in the environment, also called a reservoir. Reservoirs can be in the human body, such as the skin, digestive system, mouth, throat, and lungs, and in the blood. Consider a reservoir such as a medical device, like a stethoscope for a provider or a nurse. Disinfecting that stethoscope between patients can prevent germs from spreading between reservoirs from the environment to a patient's body, their skin. Next slide, please. For germs to spread and cause an infection, a few things need to happen. Let's talk about what some of these things are. Germs move from where they live, in body or in an environment reservoir, to another place or person via a pathway. Germs need a person to infect. That might be a UIO staff or a patient who is already sick. Through activities and procedures that get past the body's defenses, such as chemotherapy, steroids, and IV intravenous insertion, touching, reuse of devices and equipment, UIO staff have multiple interactions with opportunities for germs to spread. When germs survive, they can spread and continue to infect. Next slide, please. The element of pathway helps us realize where there are germs, how those germs might get somewhere else, and what infection control measures are needed. Things we do in healthcare can be pathways for germs to be carried from one reservoir to another, or into spaces that they are not supposed to have any germs at all. The four main pathways for germs to be spread from reservoirs in healthcare include things we do in healthcare can be pathways for germs to be carried from one reservoir to another, such as hands. Hands touch almost everything. There our universal pathway with touching devices, different people, and different surfaces. Breathing in of respiratory droplets from coughing, sneezing, or speaking is another pathway. The third pathway is through splashes or sprays of blood, body fluid, or water from a sink or other source. Germs in these splashes or sprays can get into a person's eyes, nose, or mouth, or even into a cut or break in their skin and cause infection. The last common pathway is through clinical care tasks or procedures that bypass or break down the body's natural defenses, like when a patient's skin has been broken or when an IV has been inserted. This creates a pathway for germs to enter the patient's body. Next slide, please. We can use standard precautions with the approach of risk recognition of these 5 elements and these 4 pathways to maintain infection control. Moving beyond hand hygiene, PPE selection, cough etiquette, sharp safety, injection practices, and proper patient placement, how do we rethink our infection control measures? Next slide, please. When identifying breakdowns in infection control, consider the germ and the initial reservoir with some possibilities for each of these 5 elements of germ spread. In the end, a patient could be infected with this germ. By thinking through the elements of how germs can be spread, we can better identify and address an infection outbreak before it happens. Next slide, please. Each step here builds upon risk recognition with step 1, identifying the risk, step 2, evaluating the risk, step 3, implementing the risk with a mitigation plan, step 5, evaluating the effectiveness of those controls. With risk monitoring and reporting, a regular review identifies these risks and provides a progress update and guides action steps to improve our risk response strategies. Next slide, please. Addressing risk recognition in infection control depends on input from administration, patient care, and environmental control perspectives to ensure a safe environment for healthcare. This includes monitoring standards for reporting errors without fear of reprisal for workplace injuries. Next slide, please. This assessment tool by the CDC supports risk identification with risk management in your UIO infection control program. The summary guide is based primarily upon elements of standard precautions and represents the minimum infection prevention expectations for safe care in ambulatory care settings. These tools may also be used in healthcare facilities to conduct internal quality improvement audits with evaluating infection control measures and systems by addressing these gaps. Thank you. I'm now going to transition back to Kyle and hand it over to him. Thank you.
All right. So thank you very much for that, Karen. All right. So now I would like to welcome up our next presenter. All right, who is Marie? Marie Zephyr. She is a citizen of the Oglala Nation, Lakota Nation, and grew up on the Pine Ridge Reservation. Marie serves as a consultant with NCUIH. As an ECHO support trainer, felicitator, and coordinator, Marie assists in the team's presentation adaptation. With a strong focus on culturally sensitive approaches, Marie assists in implementing infection control training for UIOs. For over 15 years, Marie has provided quality assurance, felicitation, strategic planning, data analysis, and process improvement expertise. She received her bachelor's from Creighton University in 2009 and her master's in public health policy and management from the University of Arizona in 2011. Please welcome Marie.
Mopila Kailar, thank you, and Lakota for that nice introduction. Mitakyapi, our relatives. My name's Marie Zephyr, and I'm a member of the Oglala Lakota Nation. I now reside in Rapid City, South Dakota, and I'm honored to be a part of the NCUI's Project Firstline team. I'd like to thank Kyle also for acknowledging the land and various cultures of our 574 federally recognized tribes, as well as that this land is all of our nation's ancestral territory. And in that acknowledgement, it brings us together. I also would like to note that urban Indian organizations, clinics are, a lot of the patients are American Indian, Alaska Natives, actually all of them, and are often transient from reservation to urban areas. This also aligns with our traditional nomadic tendency to move from place to place, but it also leads to a gap in data that concerns us because there's often skewed data with these tribal members and they could fall through the cracks and are also in need of that extra layer of protection from not only the different strategies we use, but UIOs and integrating data-driven tracking systems, particular to their quality improvement initiatives. I'd also like to take this time and thank all of the urban Indian organizations and your commitment to the American Indian and Alaska Native people. I know healthcare work isn't always necessarily an easy or a thankful job. People, sometimes it could be thankless, and I appreciate your commitment to American Indian and Alaska Natives. Next slide, please. Okay, as a consultant, I'm giving full disclosure that any tools or resources or even recommendation are not proprietary in nature. I also don't discuss information that hasn't been approved through the CDC or NCUIH. Next slide, please. So why do we need quality improvement or QI studies in healthcare settings? So QI can support infection risk recognition, and it also serves a purpose of decreasing patient and health worker harm. And quality is everyone's job. We all have a role that we could play in the quality improvement of our healthcare settings so we could provide the best patient care, because ultimately that's what we're all here for, is the patients, right? The CDC states that a common thread has emerged that focuses on continuous improvement and operational excellence. And this really brings public health programs, agencies, and the health system together. Our ultimate goal is to create positive changes. We want to increase patient and healthcare worker safety. By implementing new process changes such as employee orientation or even a facility-wide one, another recommendation is department-specific orientations, we can monitor and impact continuously the data that assesses whether or not our changes were actually improvements. Next slide, please. So quality improvement study tools are available through various organizations, but the CDC has some existing tools that are in direct alignment with the Accreditation Association for Ambulatory Healthcare, or the AAHC's. They're elements for quality improvement studies. They provide 10 elements for studying QI, and they use the PDSA model that I'll go into later in this presentation. NCUIH also follows the model, and we can actually help you develop PDSAs as a form of technical assistance. So as shown in the slide, the P of PDSA is the plan. And this really goes over the purpose of the study. It helps us to identify performance measures, goals, and objectives. And it helps us to describe our UI specific data and continuously monitor it to evaluate and analyze whether or not we're making an improvement. The D of the PDSA, or do, it helps us to provide evidence of data collection, whereas the S will do the analysis and comparison of performance versus previous processes. And the ACT, they really help us to implement corrective actions. So that's the PDSA in a nutshell. Next slide, please. So UIOs can identify breakdowns in the IPC process or the infection prevention control process and align them with improvement efforts that are conducted by staff. This graphic shows the process for conducting a risk assessment, training staff on that risk recognition and infection control, then assessing and reassessing the specific aims for impact. Do not recreate the wheel. The CDC has many tools for education and training materials, and they're available for use on your website. The slide demonstrates availability in addition to the PDSA. There's RCAs, IPC tools. You could identify specific risks through a risk matrix that involves frontline health workers. And there's other resources that NCUIH also developed through Project Firstline to help document these and regularly monitor your data. The data really shows our improvement. It helps us assess whether or not our continuous quality efforts are effective or not. It helps us to recognize outliers and special causes that will impact our patient care. And it also integrates proper training for frontline healthcare workers, staff, and all staff, so we could address the issues at hand. It's important to regularly monitor these breakdowns when they happen, and it also helps to prevent future issues in our urban Indian organizations. For example, when speaking about infection control to administrators or frontline healthcare workers, we could integrate them in the team that helps create the PDSA, and the frontline healthcare workers might have perspective that administration doesn't. Training staff on proper cleaning, assisting them in the development of policies and procedures, also helping them to identify where those are located during times of surveying. That will help to address the different outbreaks that we have, as well as integrating their time and opinion in the process development. It goes a long way. And Project Firstline's training really has all of these monitoring tools existing. They have PowerPoints, they have facilitators packet, as well as templates that you could use in this quality improvement process. Next slide, please. Now we're going to discuss the real life IPC breakdown case, and we're going to have a discussion after. Due to the protection of patient health information, we'll seize the recording, and that will allow us to have a discussion. So I'm going to go ahead and ask that we seize the recording.